I'm Councillor John Ogle, the Chair of the Committee Adult Social Care and Public Health Select Committee, and I would like to welcome you all to this meeting Select. This has been broadcast live and recorded for publication. Can you make clear when you wish to speak? We'll have people looking out for you, but it's not going to be as easy as it is normally in the chamber. Thank you very much. Right. Is it your wish that we accept these minutes as a true and correct record? All those in favour? Thank you very much. Apologies for absence. Apologies.
We have apologies for Councillor Steve Carr under the category medical reasons. Thank you, Chair.
Thank you. If any councillor or officer has an interest in any matter on the agenda, you should declare it now. Please raise your hand now if you have an interest to declare. None. Item 4. Progress update on the discharge to access model in adult social care under the emergency care services. I now ask Jonathan Wheeler, the Cabinet Member for Adult Social Care, to introduce this report.
Yeah, good morning, everyone. So really delighted to be able to have this report today. So as I mentioned briefly in my budget speech last week, I'm sure you all remember intently, was the fantastic news really about what we're doing around discharge in terms of working with our hospital partners. So myself and Tom have actually been to see in action Kingsborough Hospital, the great work, partnership work between the NHS and our cancer teams to make sure that if people are ready to go home, if they're ready to be discharged, we get them home as soon as possible, because obviously we know the huge cost of keeping people in hospital much longer, both financial and to mental health. So we want to get people back home as soon as possible. As I say, the fact that we have managed to halve the number of people who are waiting in hospital ward who are willing to go home is a fantastic achievement to the whole team. So I'll hand over to Kevin to take through the report. I'll be ready to take some questions. To Mel to take through the report. I'll be ready at the end to take any questions.
Okay, so just to remind the committee of why we have oversight of this agenda here. So I think it's taking you back to about 18 months ago. So there was concern from members and from committee about the escalation in the media of our acute care partners, raising concern about the impact of adult social care on hospital delays, and the urgent care system was in a state of escalation, and where there was national oversight. So there was a national oversight programme that was holding the integrated care board and partners to account. So committee decided to keep a close eye on this agenda, which is why we're reporting it here. And I would recommend that probably this is the last time, given the report, if you feel assured that this matter is now resolved, this risk is resolved, that we would no longer be having regular updates on this report. That's my recommendation to committee. Just to talk you through some of the issues, and I welcome Gemma Weissel, who's worked in the Integrated Care Board as the I can't remember, Gemma, your title at the moment, but you have oversight at a senior level of urgent care, and Nicola Peace, who's our adult social care lead for the work in the transfer of care hubs, who can answer some questions if you so choose. But just to sort of, I think I'm really pleased with the progress that we've made, not just as a council, but I think importantly as a system of partners around this. And the culture change particularly has been quite significant. So our staff wellbeing has improved tremendously. The outcomes from people, and there's some stories in the paper here, the people experience has much improved. And our really strong performance, we've always had really strong performance in hospital discharge, but that has improved. And particularly on the numbers of people that are safe to go home and that do so directly. Because it's in our interest as a council that people go directly home, and it's in the interest of the acute care system that people go home as soon as they're able to. And I think that sort of means that we're nationally now high performing. It's been really important to get the right culture in our transfer of care hubs, to be sharing one version of data between us, understanding the numbers, which is why we had the escalation previously about whose fault was it. We now have a culture where it's seen as a shared responsibility. There isn't an apportionment of blame. It's not a blame game, which I think is quite incredible progress. So I'm really pleased that we've made the progress that we have. The report highlights the areas where we're really strong, and like I say, for me, notably, it's on how those transfer of care hubs work. I've sat in those transfer of care hubs, and you'll hear colleagues working together from the voluntary sector, from health professionals and social care, working to find solutions to people, and dealing often with people that are presenting with really difficult problems to solve. Because the reason that people don't go straight home from hospital is because they're poorly. That's why they're in hospital in the first place, but then have issues around safeguarding, making the home safe and meeting quite complicated requirements. It's really good to see how that works. So like I said, I'm not intending to talk through the report in detail. I think it speaks for itself, but really happy to answer any questions.
Thank you very much. Jonathan, have you any other officers who you wish to add anything to that?
I think if it's okay with you, Chairman, I'll ask questions first. If there's anything at the end that we haven't covered, then we're happy to.
Right. So I move the recommendations as detailed in the report, and I have a seconder.
Yeah, I'll second it.
I'm now going to open the floor for questions and debate.
Councillor Owen.
Councillor Owen, please.
Yeah, thank you, Chairman. You speak glowingly about the progress that's being made and that we're one of the top performing councils, but the report seems statistic light as far as I can tell. How many people have we got at the moment in hospital who are well enough to be discharged, for example? And how does that number compare with, say, 6 months ago? And what are the blockages to those that are there who shouldn't be there because they're well enough to go home? What are the blockages to getting them out of hospital and back home? And a follow-up question would be, in this drive to get people out of hospital and back home, and that's very laudable, what are these statistics regarding readmissions from those that have been discharged? I think we need to be a little more clear, or I need to be a little more clear in terms of progress as far as statistics, because I don't think I can see them there.
I'd like to ask Jim.
Yep.
Yeah, so what we have, Councillor Owen, and I have it, but I'm not logged in, is a live dashboard that we see as a system. And I do actually look at it quite a lot because of the previous blame game. But Nicola and Gemma are logged in and can tell you as of today the position.
Yeah, happy to give you the details. So compared to this time last year, on any average day, if you take NUH alone as our big teaching hospital, we had around 300 people waiting, and they were waiting for a whole range of things. It could be a care package, it could be pharmacy, it could be equipment, it could be a housing related issue. So these are always on a supported discharge pathway. These are complex people coming out of hospital. But if you almost compare this time last year with now, we were about 300. Today we're around about 100. Monday is always our busiest day because we've always had people over the weekend who've now been classed as medically safe to leave hospital. And the transfer of care hubs, I think Nicola will testify that Monday is our busiest day. So we have a significant number of new referrals in on a Monday, and the team are actively going through and matching the needs of each individual patient with what they need to get them home today or tomorrow. I'm happy to provide further statistics. I mean, the process is slicker, quicker, more efficient than it was this time last year, and that's testament to all partners that are part of that transfer of care hub process. And I think the other question you asked was about readmissions. So we've had a summit in November which brought together all partners and did a deep dive around people that are being readmitted within 90 days of leaving hospital. And so we've just started a multi-agency group looking at discharge, pharmacy, housing, equipment, because actually there are a whole number of reasons other than health related that these people are being readmitted. So we're just starting that piece of work as a system.
Nicola, I wonder if you could give a bit of a perspective from a social care lens.
Yeah, thanks, Melanie. I think, and thank you, Gemma. I think it's a complex picture. And I think the one version of the truth that we've developed collaboratively with some excellent support from the system lead, Lisa Marshall, to bring us all together to try to agree a shared position. There's been real progress because historically what's happened is that, as Melanie said, we played a blame game. So the 100 odd people that Gemma speaks to, on any given day. There are several reasons why those people are waiting, as you've asked about who's medically fit in the hospital that could go home. We perform exceptionally well in adult social care. So on any given day, we have a 2-day target from the day when we fit and the transfer of care hub is told. So from when the local authority knows that you should leave the hospital to us actually making it happen has reduced from 3 days in May last year to 1.8 days in December. So actually, we perform extremely well. There are several challenges within the system as a part of the reviews going on with these NHS. We're looking at a rapid action to focus primarily on the key issue that we face as a local authority is the hospitals telling us when people are medically fit and need to leave and giving us the right notice. And within the system, that seems to be one of the areas where we are particularly interested in seeing support to address those challenges.
So if I can just follow up, Chairman, what you're saying is, of the 100 people that are in hospital this morning that are fit to go home by close of play tomorrow, all 100 of them will be out of hospital.
No.
No.
Right. Well, that's
So I'm sorry, Philip, I can come in there. The main issue is that it depends on the individual circumstances where they are. So, for example, there are some councils in the north of the county who don't have any temporary accommodation themselves. So if we have someone who needs to, obviously can't go home because medically the home isn't safe for them, it might take a few days for the council to find accommodation. So that would,
I appreciate all that, but we're trying to get you talk about, well, we don't want a blame game. Well, if you don't want a blame game, let's have a reasons game then.
Yeah, so do you want to, the 100 people in Nicola today, what's the reasons? What are we doing for people, those 100 people?
Okay, you can join me if you wish. So not wishing to get into attributing blame, but if you look at reasons, of the 100 people, by 12 o'clock today, round about 10 of those will be down to adult social care, and all of those will be going today or tomorrow. So that's our target, 2 days. So we're probably talking about less than 10% of the 100 aren't going at any given time. And this is obviously day by day. Of the remaining people, they are waiting for transfers from the hospital wards to the transfer of care hub. And there's work going on with that, with additional, is it discharge coordinators, I think is the system.
Yes.
Yeah. So the hospitals are, with the support of the ICB and the discharge grant funding, are putting additional supports in to make sure that the notifications come through in a timely manner. Then there are issues with transport.
Well, what issues? Medications. Well, as far as medication is concerned, presumably a pharmacist has to write out produce a deliver a prescription. Why I'm at a loss to understand why this is so problematic when you've got pharmacists in hospitals. I mean, from what you're telling me, the left hand and the right hand are not necessarily talking to one another as quickly as they should.
Yeah, I think that's part of it. It's a partnership game with the NHS, the ICB. Obviously, we're doing from count our side and to work there. But as you say, we can't control the pharmacists or on the NHS side there. We are working the best we can. I know you know.
I accept that. Yeah. But this is a scrutiny in itself and more than one meeting. We need, which I know has been going on, but we still don't seem to have bottomed it. Are there not enough pharmacists? Why the delay? You know, we're not getting those sort of answers. All right, there's been an improvement, and I accept that.
Sorry, Chair. So those issues I think would be best dealt with in health scrutiny because they're not. Gemma's not come here to talk to the whole problems of the NHS health scrutiny. I just wonder, Nicola, with the 10. So the 10 people that are waiting today, you said that most of them are going to be going home. Do you want to give some examples of where they're going and what work involves, and if there is any delays, what is the reason for that delay?
Yeah. Okay. So what tends to happen is throughout any single day, because obviously patients are moving throughout the day. So on average, NUH, for example, which is the largest hospital, we start triaging at about 8:30 in the morning, which means that the people who have been told to the transfer of care who are medically fit and ready to go home. Of those, our social work teams triage around about 50 people a day. So all day long, throughout the day, in real time, we can see people moving to the transfer of care hub for us to discuss how they can leave. Anybody who's told to us before 12 o'clock is pretty much going to go today. Because by 12 o'clock today, we can our rehabilitation services that are run by health and social care. So we provide 303 rehab, reablement, rehabilitation places every week. That's called Pathway 1, so that's people who go home. So 95% of the people sent to the transfer of care hub today that received before 12 o'clock will probably be going home today. The rest of them will be going home tomorrow. And that happens day in and day out, because after 12 o'clock, it becomes very problematic to secure providers on the day. So the later in the day you get told, the later in the day it is, so it's harder to respond in a timely manner, which is why our target is 2 days. So it's same day or next day. So 95% of those people will be going home before 12 o'clock today. Of the remaining 5%, 4% of those people will be leaving on a pathway 2, which is to a rehabilitation facility run by the NHS that our adult social care team support with, and we assess people out of those services so that people don't get delayed in hospital waiting for adult social care assessments. Now, this means that we virtually reduce the amount of people in hospital who go to long-term care and release living. Because previously, make decisions at the wrong time. Now people have the support to re-able them and maximise their independence. Of those people, a further 1% may be end of life or require significant complex interventions, and may go into nursing support facilities with much more complex healthcare support. And some of those people we also support in our social care teams who do mental health assessments, mental health assessments, safeguarding assessments. Sometimes we go to the court of protection. So all of those placements can take up to 28 days to resolve and move.
Yeah, so I think, yeah, I mean, like I said the other day, I think as you heard, there's so many complicated moving parts to it in terms of the partnership with so many different organisations there. So having been there and seen the conversation, I think as we walked in, there was 10 or 11 conversations on with different people trying to coordinate there. It's not entirely within our gift. Well, it's nowhere near entirely our gift to get these people home as quick as possible, but we do all we can to help facilitate that. I think that's the key part of it, being that key facilitated part. And as I say, it's just about more the working in NHS, and they understand our challenges themselves. As we just said by midday there, which that's why the partnership working is really key. So they understand that issue, and obviously we have to understand the issues with the NHS teams as well. Like as I always said, Monday we always know after the weekend in hospital with that extra capacity. By the time you get to Friday, it's obviously a lot. And hospitals obviously more keen to get people out as quickly as possible. That's when people pick up as well. So we just give assurance to the whole committee that having been there and seen the work that the team are doing, we're making great progress, and it's just keep working with the NHS, all our partners to obviously get as many people out as quick as possible. But as I say, it is a lot of it out of our gifts, such as the housing side and the capacity in the community. But by working as we are doing there, hopefully we can just keep making that progress.
Thank you for those responses. Thank you very much. Councillor Bailey.
Bit hard to follow up, Philip, to be honest. But I'll try. So I know in the report you say it's gone from 300 people waiting to 150 this year, and the average has gone from 3 days to 1.8. I suppose my question is obviously we've got the outlier cases. What are we doing to tackle those? And you've almost sort of touched on that. But my other question was, there's lots of improvements laid out in the years ahead. So my question is, how far are you going to go? Already at 1.8, are you struggling to find any more efficiencies? And I don't want to say efficiencies, but smoother workings to actually address that down? Or do you get the sense that you're already squeezing the lemon after it's already been squeezed?
I think from a social care perspective, I don't believe there is any sort of significant improvements. I think the performance there is at optimum, but to sustain that performance takes an incredible amount of effort. So This is not, it's not like standing still.
Yeah.
But I think that's just talking from a social care perspective. But I don't know, Gemma, if you've got some insight as to a broader bit which we're a part, that'd be helpful.
Yeah, absolutely. So one of the key items that we agreed at our last urgent emergency care board, which is all partners in the health and care system, is that actually we want to refresh our strategy for discharge. So we want to look at each of those individual pathways and challenge ourselves around what more can we do. Taking finance aside, what other patient or person, citizen improvements can we make? So some of it is thinking through what do we know from our citizens' experience of discharge that are the small things that we can improve. And as a partnership, we absolutely want to include those. So at the last board, we agreed that we'd relook at it, as Mel said. Performance has significantly improved. We were part of national oversight, we're now not. That's all been removed. However, as a partnership, we do want to relook at what more can we do together.
Good, thank you. I know when I was a district councillor, the thing that was holding a lot of discharges up were the adaptions. It took a long while to do the home adaptions. Can you just comment on that, whether it's improved and how long they're held up with those?
Well,
some people need them.
Yeah, we're first champion on that. I think that's why we've recognised that, which is why myself and Tom wrote to the government to ask for increased funding for the disabled facilities grant and obviously to change the formula because we have different needs in different areas. We've got some councils like Rushcliffe has got a huge need and spent all their money from that we've allocated from the county council, so we're putting an extra £200,000 this year to meet that. We've got other councils who don't have that need, so obviously aren't spending the money. So we're trying to look at ways to working with the district councils to release that money, because you're right, when people are coming out of hospital or whenever sitting there and need adaptation to their homes, that can have an impact in terms of sometimes it's not safe to go back to their home, so they're obviously having to go into other facilities. But we know there's also such a huge delay as well to do. So we do welcome the fact that the government are now actually consulting on changing that. They've actually put some more money into the system. They've worked out, I think it was £2 million in Nottinghamshire, if I remember correctly off the top of my head, which £2 million sounds a lot, but actually £2 million for the whole of Nottinghamshire isn't actually a lot, considering the it'd be 50,000, 100,000 just to do work in one person's house. So we are pushing for some more money and to change the formula around, but that is an issue. But Nick, you want to touch on what the actual impact or actually has in terms of not being able to get people back in their own homes, how we've got to look after them more?
I mean, one of the things that we are doing at the moment is our colleagues in commissioning are looking at working with housing and about reusing some of the services that we have as well. So we've made some progress recently with housing and homelessness, because we have some units ourselves in the north and mid of the county that we are repurposing to try to support people with, because they're accessible to people. So the housing departments are now placing people into some of those units, and we're then in reaching with our contracts for vision home care services in those, whilst the housing department retains responsibility on how they can rehome them in more suitable housing. And our colleagues in commissioning are currently trying to look at how we could potentially roll that model out better to benefit more people.
Yeah, and
from a social, to answer the questions, from a social care perspective, have you got any material impact or delays because of waiting adaptations? I believe that we use our rehab system that you described, Nicola, as a way of waiting. Somebody's waiting at home for an adaptation. They don't wait in hospital for an adaptation. Sorry, Melanie. Yeah, I do apologise. We do not actually tend to have people waiting in hospital as a result of waiting for adaptations now, because the pathway to re-ablement services offer discharge that's accessible for people. What we're doing is sometimes they are experiencing delays at those areas, and we're looking at alternative options to support our partners with that.
Thank you very much. That's good to hear.
Sorry, to finish on that one, it's worth saying that, as a council, we are looking to obviously build more units in terms of we can support people in, but a lot of it is around working with district councils and the housing providers, because they need to be building homes that are actually easy to adapt. Because you look at our new builds now, they are very difficult to adapt for people with disability and mobility issues. And for me personally, I like to see a lot more houses that are built to the standards straight away, not just building up as quickly as possible with small houses to get as many on the site as possible, because that delays us. And actually our team in Rushcliffe have done a fantastic job when we were there with them at Trent Bridge House to actually work with developers from the start to actually say we need some more homes that are that one accessible, but it's quite a challenge because you're relying on the developers being engaged on that and wanting to do it. So it does need more legislation to actually understand that, because we know we've got an elderly population. We know we've got people with more complex needs. That's not going to change in the next 50, 60 years. It's about actually adapting that to the future. So all colleagues from District Council just asking to push that as well around the housing point of view in terms of when housing plans are looked at, etc. And we're going to keep pushing the government as well to try to hopefully legislate that further.
Well, that's good. So there's progress being made, and then there's more questions being raised by the way you're advancing. Councillor Adair, please.
This is an age-old problem. I can remember doing this 15 years ago. And at that time it was really a mess because we didn't have technology at work. You know, we didn't, and I know that Nottinghamshire Council, we actually started the development of the technology that started to help the transfer between NHS and adult social care. And I was just wondering where the digital thing of that had got to and how going forward. I mean, it tends to make a lot of progress now, and there'll always be something in the wheel that hasn't been delivered and something to be delivered.
Right.
And I also think on the back of that, you were saying, Melanie, maybe we could leave this. I think this should come back at least every 6 months to 12 months for scrutiny, just to make sure that it keeps rolling, because it's such an important thing to the local community. You know, if somebody's in hospital and they get them out, and then what do they do with them and all the rest of it. Jonathan just says, and I've got about 3 constituents at the moment who have got that similar problem, and you get asked questions, what do we do? And work with the system. So the more improved the system is, the more and better servers will be able to do. So I think the wheel should keep turning on it.
Yeah, please, sorry, Mel, yeah, thank you.
Okay, so you're right, Councillor Dare. So we're setting the way really with the interoperability, it's the formal term, between the systems, between health and social care. And it's that approach that underpinned our ability to do the next piece, was at Nicholas. And now we're able to tap into what's called Nerve Centre, which is the hospital's system. And that's so it's an extract of that I can see, and I log in, so we can see on the transfer of care hubs who's waiting in for what. So it gives that real-time ability to look at. Importantly, it's not about the data, it's about driving the right intervention. So the problem with the blame game is that then you're trying to solve something over here because the problem's over here, but everyone's saying it's over there. But with the data, everyone's saying the problem's there, and then we can solve it. So you're absolutely right about the technology. And just as a reminder that in the report I'm presenting later, so agenda item 7, we do have a really big chunk on our progress of hospital discharge. So I won't be suggesting that select committee don't have any oversight of it, just that we just use the performance report as the way to do that going forward. Because you're absolutely right, having an eye on it is really important.
Thank you very much. I think we've got to the stage where we can ask Martin to read out any areas for further consideration that's arisen from our discussions and questions.
It feels odd not pressing a microphone, doesn't it? But yeah, I think it'll be. I think just to note that we'll obviously look at this as part of the work programming process that we'll be doing in June, July kind of time. I don't know if if you don't bring it to committee again, because obviously there's lots of things to look at. I don't know if members would kind of like some kind of like briefing outside. I'd say it's just some a short written briefing like every 6 months, just to let them know what's going on. If members would find that useful, because that's what I was kind of getting the feeling from the discussion. Just with some of like the facts and the data and the figures, just a very short note, really.
What are we looking for, Reg?
Yeah, I think it's important to keep the focus on it.
Yeah.
If you keep the focus on it, then obviously, I'm not saying people won't do their jobs or anything. It is important to keep the focus, a deadline, and that sort of challenge there all the time, is to make sure it's going as it is and it's improving.
Thank you, Reg. Thank you, Martin. So I note the recommendations have been removed and moved and seconded, and take a vote. All those in favour, please. Thank you very much. Item 5. Progress update on the Adults Technology Enabled Care Strategy 2024-27. I think Reg's question actually imposed on this, but never mind. I ask Jonathan Wheeler, Cabinet Member for Adult Social Care, to introduce this report.
Yeah, thank you, Chairman. So, as you know, we've been talking a lot about technology and difference that can make to not only the council financially, but also to the people who are looking after the carers and their families. Because having seen it in action at a demo flat along with Tom there, and having spoken to our teams who are out there with this technology, it is making a huge difference. And we do reference that in the report. The fact that in year one, we've got 508 carers being supported, you know, actually smashing the target. We had 442, and the fact that 46.34% of people now have tech service provided shows the rollout we're doing is making a huge difference. And I think for me, looking at the reports that come out there, and that families can actually have a real-time report to actually know what's going on with people that obviously the family members being looked after, makes a huge difference in ways of peace of mind, especially if you're not living close by to them. And they say the range of technology out there, we know crucially it's going to make a huge difference financially. We talk about the report there, but as I say, the difference in care and being able to adapt it has been keeps me around the education, I think, in terms of making sure people actually understand why we're doing the care, and especially when you're first looking, it's not looking like it's just doing it to save money. It's actually the benefit and additional benefit is for a financial save, but actually to make a lot better. The example I gave before, I think, is around having the technology on, for example, the fridge opening or the kettle going, means that when a carer comes in, especially if they look after someone with potential dementia, they can actually tell, has that person had breakfast? Have they had a cup of tea a couple of hours ago? Because unfortunately, the person they're looking after may not have remembered that they've had that breakfast the day before. So actually, in that distress you can actually cause by effectively telling someone they've got tea, they are hungry when they know they're not. You actually having a look at technology to know that actually they probably have eaten. I'm going to check on that one and look at more detail. Can obviously not only make a huge difference to that person's well-being, but also to the carers themselves to have that picture before they get in. So I think before I go any more into it, I'll bring in Katie to talk a bit more detail. I'll come back at the end. Thank you.
So I think just to remind ourselves that we agreed our tech strategy at Cabinet last March. So we're coming to the end of our first full year of that strategy. Although we've got a lot of experience of implementing telecare and some of those things for quite a lot of years before that. We set our own targets, and this was by looking at good practice elsewhere. We had an organisation with expertise that helped us, and this is, I think we feel really pleased that we are able to demonstrate the impact of technology. There are some really powerful stories in the slides. We might want to just flick onto the next slide. From this one, which was somebody's mum that had a serious fall in her own garage, cut her head, but because she got wearable tech, she was able to press that and could come out really quickly. Otherwise, she may well have been lying there for a few days. But right through to technology where we can, we've had lots of families that have worried about relatives, that they were up at the night and they weren't safe and they might be leaving their house and possibly needed residential care. And that when we're monitoring technology in, it shows that actually the risk isn't that high, and that they are going to the bathroom and the kitchen and making food, that they can stay independent for longer. We've got stories from people themselves that said they'd lost confidence and thought they might need residential care, but with supportive technology felt more confident and realised that they didn't need to go there. And through to our carers, who are really, really important for us, and carers that have experienced really high anxiety and stress, worrying about their relatives, and that technology, for 89% of our carers, technology has enabled people to feel less stressed. And for lots of people, not waking up lots of times in the night to check on somebody or check your phone because you've got alerts. So our strategy covered a whole range of areas in terms of a cultural shift, enabling staff to feel confident to use it, having a bigger offer, looking at overnight support. So we've got a story later in the report where we had people coming out of hospital into their own home in supported living, which was a really big step in terms of independence. But then taking a steady risk management approach, we then took out the night staff, which can feel really intrusive for people, and put technology in so that staff could be alerted if they were needed, and people feeling much happier with that as an approach. It also saved money doing that as well. But also looking at the kind of kit that people have got in their own homes. We've all got technology that we use well and some technology that we've got
use very well. So starting to look at how we can help people to use what they've got, and thinking about digital inclusion. So that's been the range of things that we've been looking at in the first year. We've got the next slide that outlines some of our impact, so that we know that we are supporting about just over 46% of people receiving care and support with technology, and we are well on track to hit our 50% target by the end of April. These stats came from our December data cut, so we have actually got some that are even improved from here. So where we talk, we've already exceeded the number of carers supported, but that's jumped from 508 to 647. Our referrals, which also shows that staff are feeling more confident and identifying where people could have tech, that's moved from 30.1 to 31%. Where we've got 193 people assessed as high risk of requiring residential care, that's where we are under target, but we've done a number of things to support staff and build confidence and put some more support into. We've got Mark Douglas here from our tech team, so we've got some more support to go out and put the tech in, and that has already jumped from 193 to 237. Against a target of 390. So since putting more support in, that is now jumping up. We've got more than 601 staff trained. We've now got 834 staff trained. You can see that lots of people have attended some of our demonstration flats. 82% of people report feeling more independent, and staff are feeling a lot more confident. And we're certainly seeing that. So it feels like a really good first year in terms of expanding that, making people feel more confident, and we can see the impact. We've got a couple of areas. I've just talked about one of them. So that target, that score has moved up significantly. And then we've got a second one where we've got, we challenged ourselves to have 175 people where we were using activity monitoring systems to provide early warning of a person's decline or inform their care reviews. So we've looked at how to support staff more. We've got more support from Mark's tech team to go out and fit more tech. We've put more training in place, and we've put a new referral pathway in place. So we're expecting that to move up quite quickly as well. And then the rest of the slides have got some of the stories of difference, which I'll leave you to read in the report.
Great. Thank you very much, Kate. Yeah, and I think you can just see there, the examples. And in terms of bringing up one more final example of account chairman, carers. So I talked at the start about the pressure being used on carers themselves. We've seen 89% of our carers say it's reduced their stress. And the example I remember I was given when I was talking to him was living carer who just fancied going to the pub to have a drink, to perhaps see their friends there, but was not worried about going and leaving the person they're caring for. So just having the walkie-talkie where the person looking after has got walkie-talkie, they're at the pub, which again will come to them if there's any problems or errors, to not only any alert from the system itself saying there's an issue there. So you can go and have peace of mind, switch off, have a drink, enjoy themselves, but knowing that the person looking after, if there is an issue, they can get alert and go straight home. And that difference it makes on mental well-being, I think cannot be underestimated.
Is that complete report, Councillor?
Yeah, I can talk forever, but I'll let everyone come up with their questions first before you listen to me.
Right, in that case, I'll move the recommendations as detailed in the report. I have a seconder.
Yeah.
I'm now going to open the floor for debate or questions. So, Councillor Bailey.
Thank you, Chairman. Sorry, I may have missed it, but the 390 target, you said you've improved that since December. I know on the report it says 193. What's it to now?
237.
237. Okay, so I suppose the base of my question is I remember having a long conversation with Matt Barney when I was asking about technology, how this is going to save money. Are people really going to adapt to it? I suppose in terms of the positive case studies, great ones to put here. Of course, it also comes down to money. As you mentioned, this is about making savings as well as improving care. I'm concerned about these KPIs, to be honest. I suppose making improvements since December is good, but the fact they were very off track even until December, I suppose my concern is that I was off the ball a bit earlier on in the year, in particular when it looks at staff training. 600 in December, I have a target of 1,000. But I suppose what my question is for the next year, what are we doing to make sure because we can't just hit the KPIs now, we have to go beyond them. We really have to accelerate it to keep on track. So I suppose my question is, what about next year? What's the plans to really make a dent on this?
Yeah,
Councillor Wheeler.
Yeah, no, thank you, Callum. I mean, like I say, of course we want to hit the targets. That's why they're there. I think it's worth saying it's hard, especially to hit that target very early on in the start of the year. You know, you're working up to that because it took a lot of work, especially with quite a new strategy. And again, with people with long-term care and high immediate risk, it's very complex part of that as well. So in terms of the technology, we want to make sure it's right for that person rather than just saying we've given the technology. It's got to make sure it adapts to their particular needs. So as you've already said, the progress we've made since December to really bump up that figure, and where we're going to get to the year end, we're going to get absolutely as close to that target as possible. But obviously, it's not just wanting to hit that number; it's about trying to get there. It's making sure it's the quality as well as the quantity to hit that. But I don't know if you want to think anything more on that.
Yeah, absolutely. So in terms of people trained, we've also moved up, so we're at 834. And I don't see why we wouldn't get there. These are targets that we've set ourselves as indicators of that culture shift. We've exceeded lots of our own targets and met them. We are tracking the impact of lots of that. We know that we would have spent more than 2 million more if we hadn't put technology in, because we track all of that. So we've had quite a significant cost reduction. But we've been doing that in the right ways, and there's a lot of learning in the first year of a strategy. So we've been making sure that as people are coming in to requiring care and support, we are doing a tech first part of our thinking, because it's much easier to do that with somebody when we're first putting support into place rather than put staff in and then take them out later. So we've been doing it that way round, which has been really good. I think in the couple of areas where we're not at our target, there's also understanding how, you know, because I think we've got staff feeling confident, but then you might have a member of staff that only goes out and fits tech or uses it every couple of weeks or every few weeks. So that's why we've put some more support into Mark's tech team that can go out and support that as well, to help bring that confidence up. And we've certainly seen that jump in the one target, and we've put a referral process in to help with the other target. So we would expect that to jump now. But overall, we're really pleased with what people are telling us about how confident they feel about using the tech, carers, and we can show that cost reduction as well.
I think it's worth saying as well, is that it's trying to do it the right way, because you could each say a lot more money was saying, right, technology is in every flat, no matter what, we're taking carers out, you're having technology, like it or lump it, but that's not the way to do it, because you need to make sure that people looked after feel safe with the technology, that they understand how to use the carers feel the same, and our staff, because the last thing we want for people's well-being is to just go, here's technology, we'll see if they don't understand how to use it, not wanting to use it, and potentially have falls in the home or have that extra anxiety. So it's that education part. I think, again, Katie, tell me if I'm wrong here, but the fact that to start with, by the time you get over that initial where all the staff are then trained and feel confident, and the carers do there, when you look at roll out year 2, year 3, that's going to be a lot smoother, because those people are trained up now. When new people are coming to the system to look after, that confidence is there with the system. So it's much easier to promote the technology, how great it is, to talk about it confidently, to give the examples like you've seen on screen there to people, to families, to go, actually, this does work. Here's some examples of how it can do there. But when you are starting something out from fresh, of course, to be some people going, well, can you prove it works? And of course, you've started something from day one. You can't say it can, because you've only just done it. But in terms of some examples, I say, when we're in the flat C, if I give just one more, having a sensor map, for example, someone having a fit in their home, we thought that was there. If the carer is just left, not going to come back potentially a few hours a day, if someone has that fit an hour later, that could have a massive impact on that person in terms of, of course, it could be fatality. The fact that you've now got that sense there, so it's giving that message to the carer to go, this person just had a fit, needs to get someone straight away there. That's potentially life-saving. And so having that technology there does make that huge difference. So I think the fact how we can give that real examples to people, they see how it works, can hopefully really help this to not only roll out quicker and more effectively, but to really get that confidence in the system. Because I don't mind saying, before I was kind of when I first saw it, I thought, how can that actually work, technology? How can it? When I actually went to the flat, spoke to people, I was completely sold, because actually seeing in action, I know the difference that could have made to my own gran. You know, if it was about 10 years earlier, that would have made a huge difference to me. My gran living in London, me up in Nottingham, to actually see that, because you're just relying on, of course, everything's fine, job, and of course, the phone, you know, that old war mentality. I won't say that everything's wrong, etc. That would have made a huge difference to my peace of mind and my family. So knowing that would be to people there, I can only imagine the relief there, and actually knowing that give that peace of mind and to understand that that's we want to make sure that everyone we came for has that confidence that they're being cared for the right way and that families do. And I really think this is the future to make sure that happens.
Thank you very much, Councillor Wheeler. Councillor Martin.
Yeah, I'm obviously up for the tech revolution. As the Reg knows, we at the County Council had the Smarter Working Programme introduced in 2017, and it revolutionised adult health and social care and how the care workers work. So what I'm particularly interested in is the process. So do we use can we embrace their technology that they already have first approach, or are we just going in and giving them new stuff? Right, and my other question would be about, I know this sounds a bit gloomy, but on the other side of it, returns process. Is it a robust returns process? Because I know when we had, a few years ago, we were talking about bringing wheelchairs back and crutches and all that kind of stuff. This is much more expensive equipment. Yeah. So that's why I would like to know that we've got a robust process in place that actually works.
Great, that's it.
Yeah, so I think we just got to remember that this isn't separate to the normal social work process, which is that we meet with somebody, we assess their needs, that's our statutory obligation, and we work out with them and their family how best to meet those needs. And within that conversation, there'll be an element of understanding about what activities they may want to do in their local area. There'll be something about how we work in partnership with health, about how you've heard earlier on. So we work alongside health services. There's the equipment that you've mentioned, so the ISIL stuff, so your frames and your adaptations that have been talked about earlier. And then there will be the bit about maybe how technology could enable somebody with monitoring, wearables, a whole range of things, and then care. So the care that somebody receives to undertake, prompting, personal care tasks such as being supported to wash and dress, maybe going out. So it all comes from the social work bit of it, so that hasn't changed. But I wonder, Mark, whether you might want to talk about how, because we don't really normally recycle the kit, do we? But just talk about from your perspective how you support social workers.
Yeah, so just to come back to the first question, Councillor Martin, it's definitely an issue. We've got a specific theme which is looking at how we utilise people's own devices, because obviously lots of people already got smartphones, for example, they might have smart speakers, but they don't necessarily realise how they could use those to help meet their social care needs. So been very fortunate, we've got some money through the Accelerating Reform Fund, and we've got a development post that's working with Nottingham City Council to develop a range of resources to support people to use their own device. Case mentioned that we're changing our referral process, so part of that a new referral form we've got captures information about whether people have their own device and also whether they have an internet connection, so it's actually quite key. Going forwards, we're hoping later this year to start using equipment that actually integrates with people's own devices. So currently, for example, to alert a carer, often we're having to provide a device to provide the alert to a carer in the same property. But going forward, we're hoping to start using some equipment that will actually send a message basically to somebody's own mobile phone, rather than us having to provide a device. So we're definitely moving in the direction of making much more use of people's own digital equipment to meet their care needs. So second question was around recycling. Yeah, some of the equipment we use is not recyclable. So, for example, bed pads or bed wetting sensors, for obvious reasons, we can't reuse those and they have to be disposed of. But we have a collection process. So as soon as we get notified that somebody no longer needs the equipment, we arrange to go and collect that, and it goes through a test, clean, and refurbishment cycle back into our warehouse to be reissued.
So people who transition from the initial release from hospital and then go into paying for themselves for their own care, do they have to pay for the equipment, or is it given?
Well, the rules of legal services advisors that we have to align with the same rules for community equipment services, so we're actually not allowed to charge for the equipment. We do charge a service fee for any elements that are regarded as service costs, so that would include things like monitoring equipment. So around 1,800 people are linked to a 24-hour monitoring centre, obviously the council has to pay for that, but we do include that in the service costs. Some of the equipment we use uses SIM cards, mobile connectivity, and again, we charge that as part of the service fee to the customer.
Yeah, just trying to understand, you know, people who pay for their own care after they've gone out of the adult health and social care bracket, who need continuous care to stay at home, so they're sort of like having to fund it themselves then, if they're like means tested to pay for their own care.
So our service is for people entitled to state funded care under the Care Act.
Yeah.
So Mark's team don't support people who are funding their own care. As you know, there are people that do have state funded care that make a contribution to their care, and we would use our charging policies in the same way to work out their contributions to care. And as Mark said, that there's some rules that we're advised on by legal services about how we do that. But yeah, we're not supporting self-funders here.
No, I know, but the technology will be, won't it, initially? Just like when they come out.
Well, I don't know if I'm misunderstanding.
We would provide the equipment to somebody being discharged from, at the point of being discharged from hospital.
Yeah.
So we're not permitted legally to charge for that equipment. It comes under the same rules as community equipment.
Right.
Under the Care Act, you're not allowed to charge for that equipment. You can only charge for what are classified as service elements. So the two examples I would give would be where it's being externally monitored and where there is a mobile phone cost that the council's incurring.
Yeah.
Have you got the?
So if somebody with Southend funding, we would charge full cost recovery for that individual. So if somebody was assessed as being relatively poor,
Yeah, I'm just trying to weigh up the difference between the two.
Yeah, it's the same policy as we did with the rest of the area.
So I think we got there, Councillor Wheeler.
Yeah.
So Councillor Dare, please.
Yeah, you have in the report here, reduce the number of building locations from 10 to 8, services being delivered as follows, and this is in 30.
I'm sure you.
Is that struck?
No, you're right.
No.
Yeah, it's like the day opportunities one, very sharp. That's the opportunities one. Unless I'm wrong.
Item 5.
I'm on item 5, aren't I?
It's just
Oh, I'm sorry, it's later.
yeah.
Right, just hang over to the next one. You haven't got that. Councillor Kerry.
Thank you. You showed some examples of how it's worked in feedback from service users and families and all that. Are there examples where it's not quite worked or hasn't worked, and obviously you've got a culture of learning, organisational to make it improve, where actually having gone through the painful bit of it not working, you've got better at doing it and delivered improvements?
Yeah, I think absolutely. In any change where we're trying to help staff to feel really confident, we've seen that steady increase. I think the referrals have been a really good indicator for us that have showed us over time more people are referring and identifying the opportunities. But also where we've been trying to use technology with sensors to monitor people's patterns in a home, for example, we have had some learning around people feeling confident to go out and install that, which is why we've put some more capacity into Mark's team. So we've got what we call a hybrid approach. So either a social worker, if they feel confident, we'll enable them to go and be part of that, or if they don't feel confident, Mark's team can go and support it so that then the social worker can work with the person. And I think we've had quite a lot of learning in this first year and feedback from teams, absolutely. And that's where we've now put in a new referral process to, as Mark's just given the example, we can now much earlier see, well, what equipment has somebody already got in their own home that they already own, and what can we do with that? So there's a lot of learning coming through, and I think there's still more learning opportunities.
Thank you.
So
I'll
that's
just make a comment on this one.
okay, Councillor Dare, go ahead.
Unfortunately, I'm not that age group where I know a lot about people. One of the things is this facility is not well recognised in the community. It's not well acknowledged in the community. And there are people out there who probably could benefit from it. They're not benefiting from it. How do we get that message across?
Yeah, I think you're right, Rich. It's about education, communication. Part of it is as part of the rollout. You know, we actually want to showcase how great it is there, and we'd have to look from a content point of view what we can do. Because again, I was saying when I went around Tech Flat and saw an operation, it completely changed my understanding of it. So we want to take that away and look at how we can educate more people about the fantastic use of it. I think the fact it's now getting to the stage it is now where we've got the evidence to show, as we've just shown on screen, part of the strategy means that's a better picture of strategy to tell, because a lot of people might say, well, of course you're going to say it's great, but we can actually give the real life examples. So obviously we want to roll that out. Anything you want to
add? I think it's fair to say in society generally, there's lots of tech in all sorts of ways being sold that lots of us buy and then don't use. But also I think, because some of us can remember when telecare, it was called telecare, started coming in the noughties. And I think if we'd have projected forward, I think we'd have assumed that big companies would have been selling this stuff, you know, routinely and doing a lot of marketing around it. And actually it perhaps hasn't been in the way that we might have projected. So I think generally there is space for more communication, and certainly, you know, I've been doing a lot of thinking to my own dad about the tech that we've supported him to have, and what else we could do. So I think there is a general space, but I think for us in social care, building staff confidence even further has been really important in the first year of this strategy. Thinking about supporting individual people and families to trust in some of this has been really important. There's a lot more to do, and we've got a whole work stream that is about digital inclusion, as we're identifying people that could benefit from technology. But I think after a first year of this strategy, there is more that we could do in terms of sharing some of those positive stories as well.
I've got a constituent. They're in the 80s, right? And he's fit and able, but she's not. She's got dementia and she's in bed most of the time. But he's one of these chaps that likes to go to the pub and have a drink. He's sitting there worrying about, is she all right? Can I have another beer and go back? Whereas if the technology that you just described was implemented for them, he could relax and she could relax, and both be in safe hands.
Yeah, Mark, do you want to talk about some of our information and our partners?
Yeah, I mean, we regularly attend community events. So, for example, this year we've been to a number of carers fairs, been to some dementia cafes. When we've been doing the demonstration flats and houses, we've invited community groups and NHS colleagues along to those. So we've been doing quite a lot to get the message out. But I totally agree with you. It's a massive challenge, because often the people that you need to target are the ones that are not in touch with different agencies and services, but we're obviously reliant really on community groups helping us to spread that message out. The other thing we are doing is making changes at our customer services centre. So with the new referral form that we've developed, we are doing some work with our customer services centre so that they identify people when they first get referred in, and if necessary can do a fast track referral to us rather than it going through our social care teams, which is what happens sometimes and not always. It does come through directly to us. So that should, obviously the customer service centre are having contact with thousands and thousands of people over a year, so that should improve the spread of knowledge about technology.
You have to remember there are people there who don't want to be embarrassed saying we're not right, we're not well, and they won't go to where you want to go. The other people will be piling in there like bees to a honey pot, and it's finding these other people and helping them that I'm talking about.
There are a lot of commercial companies out there, as well. I think we'd be trying to encourage residents, if people approach you, to have that look for the various options out there, because obviously the companies that we obviously purchase some of the equipment from, so they are available to people who are self-funded. So I think I'd really encourage people sort of have a look around and look at the various ones out there. It might be that there's different systems might be more suited to their needs as well.
But if there's social care people going and visiting, I know they've gone, does it?
Yeah.
But it's delivering that extra edge and getting that across.
Sure, if they ask the carers team, they'll be able to point them in the right direction to the right care for them. So technology.
Thank you, Councillor Wheeler. I think we can move on. The recommendations to this item are on page 32. They've been moved and seconded. I'll take the vote. All those in favour, please. Thank you very much. That's unanimous. Item 6. Update on the implementation of the Day Opportunities Strategy 2022-27. I again ask Councillor Jonathan Wheeler to introduce the report.
Yeah, thank you, Chairman. So as you outlined, we implemented a new strategy in 2022 in April, so over halfway now, and so obviously made some fantastic progress, which we'll be able to talk to you about today.
Right, Martin.
I think the main advantage really is to say that we are at the point where we're trying to get away from, as you said, by doing the report, from relying on the buildings in terms of making sure how we actually make sure we look after the person in the right setting appropriate to them. So I've given examples before about Brook Farmers, a fantastic opportunity there in terms of some of the opportunities we offer in the community, but there are many other ones which we'll cover off today. I think what I'm really pleased about is the fact that we've actually seen the number of people reducing who actually need the day provision itself, in terms of, because that means it's showing that there is a lot more work to develop their independence and reduce their reliance on the formal support, because it's all about trying to make sure we keep as many people involved in the community as possible, because that's really, we know the difference that can make to the people we're looking after's lives. And last thing we want is people to feel isolated and not to engage with various community activities. So if I hand over to Sal, I'll come back at the end.
Thank you. So our day opportunities, really important, and nationally and locally, we know that we've been having a big move away from just being in a buildings-based approach to a style that is fitting around your personal interests, your personal goals, more connection to part of your community, building opportunities for employment, volunteering, social connection, etc., which is promoting independence, etc. Most of our day opportunities cover that range of things, but we've also got some things that you might not always recognise as a day opportunity. So we have our Shared Lives programme, where people might live with a family, and again supporting those day opportunities and access to the local community, or somebody might have a personal assistant and a personal budget to do some of those things. Or if you're in supported living, for example, you might have somebody that comes and works and supports those goals as well, in terms of connecting into your community. So we know that we've got about 1,400 people that access day opportunities. So I've just kind of covered that strategy. If we click through a little bit more, we've got some fantastic stories and quotes and feedback from people. We work at a range of levels, from early intervention, prevention, through to some quite specialist support in our day opportunities. You just move on another one, thank you. So we support about 1,400 people, wide range of areas. The budget is almost 18 million, lots of co-production into this. The split, we have support that is external that we commission, and support that is internal through our own day opportunities teams and settings. In terms of external day services, we've got about 597 people supported externally and about 849 internally. So we've been looking at that maturity journey along that shift from being just in buildings to supporting people to be part of their communities, and we're seeing lots of new types of models over that time, and that includes we've now got community networks that have been set up in Mansfield and Hucknall, for example, which have got about 50 people all supporting each other. It's really co-production as an approach, where people work together, and it might be in host sites like a cafe, for example, but working together on how I can improve my physical activity, how I can think about my skills into work or volunteering or learning to cook and prepare healthy meals. But those people setting those goals together, working together, and we're really welcoming of that style. And with a new framework that we've got coming forwards, we're expecting a lot more of that co-productive network type approach. we've got one in Bassett Law that will start in April as well. So we'll see a lot more of that. I think what I was really pleased to see is in 23-24, 29% of people access the community each week as part of their day support, and now that's 46% of people. So we can see that as a good headline stat actually moving. There's a range of stats in the report. I won't run through absolutely everything. Part of this journey, as you know, has been also to look at our internal day centres and some of the buildings that we've had and supporting our own workforce. And we've just moved from 10 buildings now to 8. So our Mansfield and Netherfield sites have closed. In terms of Netherfield, Children's Services are using that. And in terms of Mansfield, we are now clearing a lot of the things that are housed in there. But that's been really successful. And people are now supported through their next opportunity. So I'll pause there rather than run through too much detail, but hopefully the stats in the report are showing the direction that we're going in terms of implementing that vision and that strategy that we've got.
Thank you very much. So those are the recommendations as detailed in the report, and I've got a seconder. Yep. Thank you very much. I'm now going to open the floor for questions and debate. We've got Councillor Martin.
Yeah, thank you, Chair. So I just want to focus on the personal budget side of it, because obviously a lot of the changes came about as a result of COVID and the way in which a lot of these people interacted with the day services. How do we, because obviously they weren't coming to use the services during COVID, and that's why a lot of these changes came about, isn't it? So how do we monitor those people that have personal budgets? How do we track what they're spending it on? Because I'm just a little bit concerned that some of them might not be following through and just sitting at home, to me.
I think we're mixing some things up there a little bit, David. Yeah. So yes, what we've discovered in COVID is that people didn't come to the day service and found other things they've heard. So that helped us then, I suppose, build the confidence of people, carers and staff that actually we could work in a different way. So that was why there's a relation to COVID. Yeah. In terms of if somebody has a personal budget, we have a number of ways that we safeguard that use. So the first is social work. So it'll become part of the social work assessment, and the person will be reviewed regularly. And we talk about reviews, don't we, here a lot. And then if they're taking a direct payment or using a personal assistant, we've got additional safeguards. It's mainly the social work process that will be the main thing there. Some people can talk about that themselves, but some people are more than able to take a personal budget and then direct their own care and support. So they're the safeguard then actually is their own person's experience. Carers will be other source of information, but it's the usual kind of safeguards about how we know somebody's got a good level of care and support.
Yeah, I'm only asking because it's a vulnerable group of people. I mean, there's about 1,400 in it, so altogether.
Yeah, I wouldn't say that this group is particularly has got particular needs that would set them aside from the other 13,000 people we support. I wouldn't see them as being more or less at risk. I think that this group of people require this type of support during the day. I think that's the only thing. We wouldn't say that necessarily. And some people access employment support, for example, are on that journey to seeking work. So like I said, there's a whole range of people that we would support. I mean, I would probably say that people in the autism hub and dementia hub, we know require a lot of support for the time that they're there. They're more of our intensive support bit of it.
Yeah, thank you.
Good, thank you very much. Councillor Dare.
I'll come back to the question I was asking on the previous paper, and that's all this reduction in buildings and all the rest of it is here on paragraph 30 A and B. How successful is that implementation gone, and is it working, and what's the way forward?
So Helen's behind me. So we tracked really closely the plans that we had to support people to make different choices. So we didn't close Mansfield or Netherfield until we're at the point of being really clear that people had a sort of support plan going forward that they were confident. Yeah, well, they weren't seated at one point. And we've had some really good sort of oversight and scrutiny of those individual stories. But I wonder, Helen, if you want to just sort of describe how long it took, because it was a very long process of engagement, wasn't it, with families particularly?
Yes, so we did a lot of work with families. We've had things that we call coffee mornings where we invite parents and carers to come and talk to people, really build up that relationship and reassuring people that it isn't just about a building closing. We're not talking about services disappearing. People are still having a day opportunity in some way, shape or form. In terms of those that had the day opportunity at the Mansfield building, 6 people have not gone on to internal services. 2 of those people because of ill health. 1 person decided they didn't want a day opportunity, it wasn't right for them anymore. 3 people have gone to externally provided day opportunities, and the rest have gone between our current Ashfield site and the Ollerton site. And if we look at the Netherfield building, all but 2 people have a day opportunity with us in internally provided services. Unfortunately, 1 gentleman passed away, and was 1 person who's quite ill health, and I don't think a day opportunity is the right place for them. Really, really positive. I've been really fortunate because I get to go to these places as part of my job. I've seen some really, really good examples of people who I spoke to before the change, who were anxious, as we all are about change, and I've seen some absolutely brilliant pieces of work. Think of a youngish lady I spoke to a couple of weeks ago who really was unsure about what was going to happen to her. She used to walk to her local service. So there was a change. What does that mean for her transport? She needs transport because of her health conditions as well. And I saw her the other day. She's absolutely thriving. She's making co-produced plans that you were talking about, peer support, going out for meals, really, really thriving from the changes and developing her own day opportunities. So yeah, really positive pieces of work. It's been long and it's been challenging at times, of course it has, but I think that's dedication to the wider department team as well. A lot of work from our own teams who know the people really well, work with the families, but also, we've had good support from the social work CCO colleagues as well. So that's kind of really helped that journey, so to speak.
I think communication is key, isn't it? You've got to make sure that when you are doing changes, you're absolutely setting out why you're changing and engaging people, because we see the difference between a council just across the water, where you can't just say you close something and change something without actually, especially understanding the people we're looking after and their needs. You've got to absolutely make sure you bring people on with you. And I mean, it's testament that I've not seen any complaints. They're not coming back to my desk, so I would say that's a really good sign. It turns outside because of the amount of changes that happen. That's fantastic work for the team in terms of engagement. You've seen the extra time it's taken and going the extra mile, but it's really paid off.
So with a rolling stone, what's the way forward from here then?
So one of the things that we're really keen to do is start to build up when the Mansfield Connect development takes hold. The adult social care part, that's really important. So making the most of that. Continuing with our reablement approach, which we talk at committee consistently. So we're really keen to see that the day opportunities is part of our broader offer. Because I think traditionally you went to a day centre, and then you went there and that was kind of it. You started a brilliant job of personalising the services, making you feel good and supporting you. But we didn't kind of have this bit of flow. So it was like a very static group. So we're really keen that somebody will come to the hub now and have a piece of reablement work and then go off, or somebody that's in the hub for a while will be able to benefit from that. So I think the way forward is more of that flow between the provider services, which was partly why we did the restructuring of adult social care and put the provider services together. So the short breaks, shared lives, day opportunities and reablement services are all together with that intention.
Good, thank you very much. So Councillor Owen.
Yeah, can I just pick up on and ask some clarification, expansion on one statistic? At the bottom of page 43 of the report, paragraph 4, it says there that the total number of people using the day opportunity provision since the introduction of the strategy has reduced, and the figures are given there. And if that's because they've moved on, that's good news. If it went down to 0, it'd be even better if they all moved on. But going over the page, it would appear that 26 people have positively moved on, from what I can tell, unless I'm misunderstanding the figures, which leaves a further 65 approximately who remain unaccounted for, not in the system. Well, we've been told that one's died, so that takes it down to 64. Have we got any evidence as to why those 60 odd people have disengaged with the service, if that's what's happened.
Okay.
So I can't answer that exactly, and I can definitely go away and check and come back to you. But I think I would imagine that is a range of things where somebody may not need that support anymore. It might be
So
something.
Kate, there's a time, the data doesn't match, so the paragraph 4 is referring to a 3-year period, whereas the table's referring to last year's numbers. So I think we need to go away, because I think we're reporting data that doesn't align in, so it may be that your reasons, but I think we need to just check that and get back to committee. Yeah. The periods we're talking about.
Yeah.
So is there any more? Councillor Carey.
Yes, thank you very much for talking previously about that, the change from day centre to whatever. And I thought that the response was quite interesting. So are you saying there's a possibility of introducing change as a stimulus to some of the service users? Because you talked about the way in that change did come across positively for the person that moved to the new centre.
So I think that the whole reason for this is we want to support people who actually need that support, but at the same time, if we can help people to move on to more of a community-based approach, or even not need service altogether, that's what we really want to do. Because Mel said in the past, that was like the end, was that you were in the day opportunity, you'd be there forever, or you'd be there for a long period of time. Our point is that we want people to be more engaged on a community approach, because we know the difference that makes to employment opportunities if you've got that more community-based approach, but also it may be better for that individual person if they are in a different setting in terms of around the community side. Not everyone obviously is the same. That's why they've got their own plans. So while we're always going to be there to support people, and as Councillor Endon set out, you can try to reduce that down to 0 if it's the right way to do. We want to absolutely help people to move on to that new setting if we can, because it might be the best for them. And so I think, you always see about 26 people as we identified where this year moved on. I think just, again, I know I keep saying about it, but I'll never shut up about it, is Brook Farm. Looking at the opportunity, if you go into that employment side, it may be they're there for a year at Brook Farm, learn the skills, but they might be better for them to go to another employment setting. They learn the skills with us and might want to move on to another setting, that's another employment opportunity, more hours, or a different way to do. But we've given them those great skills. So if that day opportunity is helping to people to learn those skills, get more confidence in a community setting, they can move to a different one. I take that as a positive. That people, everyone's going on.
I just want to pick up. I think you might be talking also about supporting people through change.
Yes, and I think so. It's about, so if somebody has got a long period where they're doing the same kind of stuff, and that something changes, that can act as a stimulus. So and that can actually by introducing bits of change, understanding that customer, that client, that person's needs, you can actually holistically improve them by introducing other things. Yes.
The type of things where this happens quite frequently is really beneficial, the way that we work with individuals on a person-centred basis, so that they've got their own individual personalised plans. I can think of one gentleman who I saw last week on Friday. He's moving his supported living. And it's quite distressing for him that he's been living in a place for quite some time. The place he's going to will be fantastic, but the change that you're talking about and that wraparound support of his peers, key workers, and his staff team that know him really well, helping him to transition through that change. And that in itself has become, if you like, a piece of work that the team are doing with him. So that, it's day opportunity to help with that sort of that wider change, to involve other people that aren't NCC employees to do that change with them. So yeah, there's lots of those kind of examples which are really positive outcomes.
Thank you. Yeah.
Good. So that I think that's the last. So I'll ask our scrutiny officer to read out any areas for further consideration that has arisen from the item.
I think it was just as we said earlier. I think it's just getting that further clarification that are around the figures in paragraph 4 about the actual numbers of people that have currently accessing on the change of how people were accessing before. So we'll work with officers and we'll get that circulated to the committee.
And an emphasis on the way forward.
Yeah, everybody happy with that? So the recommendations are on page 51, have been moved and seconded. All those in favour, please. Thank you very much. Item 7. Adult social care performance, risks and financial position, Q3. I ask Councillor Jonathan Wheeler to introduce.
Jumped the gun there, so you nearly got to at the end of listening to me go on, but in terms of the report here, I mean, we've touched on a lot of it today already, which just actually underlines the fact that local count is underpinning everything that we are doing in adult social care. So we've actually seen that in action today. I mean, going through the report, which I think is more important, we go through a lot more detail first and come back to questions at the end with a lot of detail in the report. I did touch upon a lot of the financial challenges in my budget speech in terms of the unexpected reduction in income from the ICB with the joint package work after they obviously undertook some reviews for their financial position. The extra cost of the national living wage, which they welcome for our team, was more than we budgeted for, more than we expected. And that was the same across the country. And the increase in costs we're seeing in terms of new people coming to the system, what that's actually cost to look after. And of course, the recent change in the budget, which had a big impact on our partners in the care system. So I'll hand over to Mel to go through more detail and be happy to take it.
Thank you very much, Councillor Wheeler. Melanie?
I just wanted to pick out a few of the things that I'd like to draw your attention to. So the first is paragraph 8, performance on adult safeguarding, which I would argue is our core purpose as a council in adult social care. People are safeguarding, as we touched on earlier, have choice and control over their outcomes at the same time, which is quite a balancing act. Which is why we measure here that we ask people about their outcomes and whether they were achieved in the process, whether we have removed the risk from the process, and then whether somebody can't articulate for themselves because they don't have the capacity to do so, that we ensure someone's got access to an independent advocate. We're very ambitious with the targets around 100% because these are statutory rights, so we want to make sure that's a reality for everybody. And as you can see, that we've been progressing to that, and part of that is about the cycle of performance in the year, but nonetheless you can see where our strengths and weaknesses are there. Waiting times has been one of our key operational risks in the pandemic. So for 4 years we've been carrying unsustainable waiting times, and we've been committed to reducing those where we can. And so you can see that we've been doing that on the average waiting times in days. So the waiting times would be waiting for a change in your care. So maybe you're in supported living and you're ready now to move into housing. That would count as a wait. Yeah, maybe you're waiting for a process. So maybe waiting for somebody to assess your deprivation of liberty or give you a social care assessment or a review. So that's also counted there as waiting. And then we particularly have had an issue with freeing up occupational therapy time and waiting for things like some of the DFP works. All of that we aggregate up, and we have a chart there that looks at waiting times. At departmental level and team level, we do break that down so we can see what people are waiting for and make sure we've got the appropriate focus on that. There's a really nice story of difference about the Transforming Lives team on page 67. So the Transforming Lives work is where we're supporting people with learning disability and autism who have got forensic backgrounds. So this is where people have been normally through the justice system, have often been in NHS institutions for a very, very long time. So the average length of stay there is about 10 years, but some people have been 30 years. So this takes really close working with the person. We're making sure there's issues around victim and where you're excluded from your community are taken into account, and particularly with the NHS. So it talks about us working with intensive community assessment team, which are the NHS. So just to draw attention to that, because in the breadth of adult social care, we can often talk about things where there's volume. So, you know, how many people we support? 13,000. So this is a minority of people, but with some really important work with their outcomes. I also wanted just to, before I go on to the money, which I know you'll want to talk about, we've talked about here about when things need to change, and that's where we do the reporting on the success of the discharges and the adult social care. So I just wanted to remind you that in the report, paragraph 26 and 27, we do focus each committee on how we're doing hospital discharge, just to give you that assurance that you do see that. And then we talked briefly about personal budgets, and paragraph 24 just talks about direct payments. So this, David, sorry, Councillor Martin, is a part of the personal budgets, the direct payments. But in that work there, it describes some of the work we do to make sure things are safe. So such as the checks on the DBS is one of those examples. So just wanted to, sort of, some of the themes you've been discussing, just sort of point to it in this. One of the areas that we've been particularly challenged with, and you heard Councillor Wheeler talk about this at full council last week, is the cost of care this year. Just a reminder of the things I talked about last committee. So we faced a potential overspend of 50 million this year. We've worked really hard to reduce that down to 10 million with a number of mitigation efforts. So the things that we've been facing. So first is that the cost of care has far outstripped inflation. So for new people, it cost 18% more than it did last year. Older adults overall, 10% more. And for working age adults, 14% more. We gave 7% uplift. I was given from the council a 7% uplift on the cost of care. So the cost I'm facing is far in excess of the cost we expected as a council. The second bit was the dispute work with the ICB, the Integrated Care Board. So the Integrated Care Board had not paid invoices, and that had caused us to accumulate debt. And we worked through a process of resolution to brought that risk down from 13% to 10 million. And that the NHS have also been reviewing, it's a national agenda, their continuing healthcare and joint finance, and that has a 13 million pressure on us. I also had the living wage increase of 7 million. That was in excess of what I'd been paid for in the budget. So we were expecting a much more modest living wage increase. It was far in excess of that. So that created a 7 million cost pressure. So basically, I started with a minus 40 million budget this year. So we now have a 10 million position, and that has been from really hard work resolving the dispute with the Integrated Care Board over invoices and cost of care. Working really closely with the market through our new brokerage team to try and make sure we've got as much control as possible over the market. But for those of you that economists know, there's only so much as a buyer you can do about price. You're quite limited, especially when you don't know, not a lot of options about choice, about where you buy. I can only buy in Nottinghamshire. And then with a really robust programme of reviews. So making sure that where somebody's needs are complicated or where we're spending a lot of money or where there's a lot of risk, we're reviewing that package of care. So that's kind of, I think, the highlights from the report.
Thank you very much. The recommendations are detailed in the report, and I've got a seconder. I'm now going to open the floor for debate or questions. So we've got Councillor Dare.
Yeah, I'll just come back to money. You put me in money. This is a large sum of money that we're way off budget and way off target. You've explained some of the reasons why we've got there. So basically, the pension fund. It's also something to do with the partnership we've got with the ICB. So how we contain that, if you can't repeat that, how we contain that? Lessons learned, going into the future, well, it doesn't happen again.
Yeah, you're right first, I'll come afterwards, yeah.
So just as a reminder, 10% is quite small actually. It's only 3% of my budget. So it's a 3% variance. So it is actually, I know in cash terms, it feels very large. In terms of ability to manage a budget, it's quite a small percentage. The inflationary effects we can't manage directly, but we do try to with commissioning. And that relates to the work with health, because the people that we jointly work with NHS to provide are the ones that have the most costly care packages. And unfortunately, we can't mitigate the risk of health not paying. So the way the two frameworks work, the Care Act means I can't walk away and leave somebody if they've got eligible social care need. In the continuing healthcare framework and the way the health service works, they can. So they can decide it's not NHS. If they decide it's not NHS, it then means it's adult social care. And unfortunately, that's just the way the two frameworks work together, and which is why a number of councils are currently in legal dispute with their ICBs, which is something that we're trying not to do. So we're trying to work in partnership, offering to share our brokerage services. Yeah. We've got a team that works with commissioners, brokerage and social work that tries to to look at all of the joint arrangements, how the presentation from Nicola about managing discharge, we mirror some of that work with learning disability and autism and mental health, so that when somebody comes home, we're working as much as possible to make sure the person's as safe and well as possible, but equally at the smallest cost. It's going to be a risk that we'll be facing into next financial year, and it's going to be one of my biggest risks.
So there's a risk.
Yeah, there's a huge risk going forward with the joint finance arrangements with the NHS.
I mean, yeah, I think also that's the biggest risk because it's out of our control. Like I say with the NHS, that's why it's about the communication, trying to work with the NHS and ICB. As I already said, you think where the position we were at and where we got to in terms of reducing the pressures and the overall overspend is because the team working closely to try to bring that down. There are other councils who are in dispute, trading letters back and forth and saying how horrible each other is to each other. We're not trying to do that because it's not the grown-up approach. It's trying to work collaboratively and to understand the only person who would suffer in the day would be the people we care for. But as you say, it's always difficult when a large part of your budget you don't control. If you're in full control of your budget overall, then absolutely the buck stops with one person. But I think the fact that we are, and we don't know what the NHS will decide to do after we set the next budget. So we have to set the budget the best way we can and work to it. But it's about, I think, hopefully now with a lot more communication with the NHS, we understand a lot more in terms of where we're coming from. We understand some more of their risks. So it's trying to mitigate that as much as possible. But it is a concern, and that's why, as I said before, you can throw billions and billions of pounds at the NHS, but it's about actually working collaboratively together. Because as we've outlined today, there's a lot of joint partnership working, and as we've seen with the discharge, where the amount of money we can actually save the NHS by getting that right shows that actually it needs to be treated as social care as that partnership with NHS, not just throw money one side, not give enough money to the other, because all that happens is that risk and that pressure comes down or comes across to us, which ends up being the position we are where we have an overspend. But what I give the assurance to yourself, Reg, and to our committee is it is number one on top of the agenda in terms of, every time we meet, which is our position, most regulations, myself and Tom are going through line by line with plans with around finances, where we're asking those difficult questions and trying to reduce as much as possible. And we have teams who are absolutely trying their absolute best to reduce that down. But as I say, we do have that legal obligation, as Mel's already said there, we have to morally to give that care to people. And in terms of doing reviews, etc., with people getting a lot more complex health issues, that cost is going up. It's only going to, which is why the social care reforms are so important to bring forwards, because it's just been kicked down the road and it's not going away. It needs to be tackled head on, and whatever government of whatever colour needs to get hold of that and do it, because it's only councils like us and others who are going to put the bill on our taxpayers at the end of the day.
What you're saying to me is that budget that you presented to council last week, this element of it is at risk going forward.
It continues to be high risk for the pressures we're facing. So most of the care now, most of our budget, 87% of this money, in that we agreed at full council last year, so you agreed, is on care packages, directly on care packages. When I first started in Nottinghamshire, it was 10% less than that. So what we've done is take out as much money as possible from things like cost of buildings, administration, all of that stuff that isn't about direct care. But what that does then mean is that everything is invested in care out there for people, which makes it very risky to manage, because I can't control how much support somebody needs, and I've got limited control on how much we pay for it. So we can do prevention work, we can do technology, but at the end of the day, the people that we support have either, because of older age, have mobility issues, mental health issues, physical disability, learning disability. They're factors that I can't control or manage. So what we do, like I say, we do the things we can to manage it, but the budget, it is going to be risky going forward, as it has been increasingly the last couple of years.
Thank you. Councillor Moxon, your question.
Yeah, thanks. I'm just a little bit confused in the report about the red, amber, green status and what actually constitutes it being green. So a good examples on page 64, which you highlighted earlier. So the first one, for example, percentage of safeguarding service users who were asked what outcomes they wanted. So the target's 100%. We've only achieved between 83 and 84% in the last quarter of last year, and yet the status is green.
I noticed that when I was talking about the safeguarding page, I noticed that as I was talking that our labelling isn't consistent with the performance of the target with the actual.
I mean, there's another one on.
So usually it would be that it would be red is when the target's at risk, amber is when we project it to be at risk, and green will be whether we're expecting delivery. So it is a projection to the end of the year, but rather than on the actual targets, it's on what we expect to get to. But I would question whether we're confident when we've got 78.9%, we're really going to meet 100%
Well,
at the end of the year.
Yeah, exactly.
So I would have said that one is amber. The others, I'm happy with it being green, because I'm expecting we'll make target.
What, even the last one?
No, that one I'm saying, the last one I'm saying, I'm looking at it, I'm a bit worried. The other issue is as well is the delay. So this is like a 6-month report to December. So the data is quite old by the time we get it submitted, but even so, with that performance in trajectory, that's not showing that we're going to have such a big jump in performance. But the others, I'm confident will be delivering.
So sorry, just to clarify.
Yeah, of course.
Which ones are you confident on and which ones aren't you confident? Because the first one and the last one on that table look like you're not going to achieve the target.
No, I'm really confident in asking people about their outcomes, because that's a really basic practice that social workers should be doing. That's really simple. The social workers should be working with the person asking, and then we have a category where if somebody can't express that, because we do safeguarding for people that have passed away, for example, so we should be taking that out of the target. It's the last one on the table that I'm less confident.
All right, thank you very much.
And although we may not be 100% nudge on there, we are making progress towards that, and we will keep. I'm sure that's going to keep make sure we get as close to that as possible. I say 100% is always very difficult. Obviously, a lot of these are legal targets, and where we think we have to aim for 100%, because it's only right to have that stretch target for some of these. So agreed. We'll look at to make sure the labelling is consistent going forwards, but with that assurance, we're going to plan to get as close to that as possible.
Good. Well, Lisa.
Yeah, what I might do, because the other thing that isn't clear on some of the tables, like on page 66, is that low is good. So what I'm going to do is take that with the report, so we can be really clear. Are we given a confidence level? Is it an actual target? And then do we expect, is low good or high good in terms of numbers? So thank you. That's my take.
Thank you very much. Move to Councillor Owen's question.
Yes, I was going to ask a similar sort of question on that, on page 64. I don't think you've admitted that you're not likely to reach the target. Almost a fifth of current projections who were asked, the service users who were asked what outcomes they wanted, I think is not good. I think it's poor. But I was particularly interested in the second one, the percentage of safeguarding service users who felt they were listened to and their outcomes achieved. The actual that we achieved in 23-24 was 95.4%. Yet the target for 24-25 was less than we achieved in 23-24. So we were expecting to not listen to more of our service users than we had done this current year, than we had done in the previous year, according to those figures. And I would have thought a target. I would have thought a target for that ought to have been 100% as well. That just seems a bit of an odd state of affairs. I also wanted to just make a few comments on paragraph 35, the black hole that you referred to perhaps is not such a black hole. You say it's a fairly minor deviation from your overall budget, and therefore you should have no problems in filling that black hole, because it's such a small black hole. But what concerns me is that the ICB, and we've got no representatives here now this morning, can just on a whim say, well, we're not going to pay our bills. The money, their money, is the same as our money. It's all taxpayers' money. And we really, the cabinet member talks about a grown-up approach to the ICB. Perhaps we ought to throw a few more tantrums with the ICB and tell them what we really think about them. And if that's being less grown up, well, I'm all for not being, in my dotage, I'm all for not being so grown up. Because I think this is a deplorable way to conduct business in the public domain. All taxpayers' money. Clearly, it's up to the new select committee as to what they do going forward. But I would have thought we ought to have had representatives, the ICB here, or the new committee did, in front of them for an explanation as to why they are behaving in this sort of way. It's very nice if you can say, well, we haven't got it. We need to cut down a bit, so we'll not fund this. Somebody else can do it. That is not the attitude at all. And I think perhaps we should stop being quite as grown up, if that's what the phraseology is that you're going to use, and get them here in front of that select committee and say, what the hell is going on? Why are you creating problems like this? Because it's not as even if it was planned. It was just done on a whim from the way it's been described to us this morning. Now, I would like to hear, would have liked to hear their side of the story. And unfortunately, they're not here. So I would suggest, Chairman, that is something that ought to be done going forward. Thank you.
Thank you, Councillor. And would you like to respond, Melanie?
So we have worked with the ICB now to resolve the dispute. So that behaviour has actually ended. And as I said, we're now getting to the point where we're having a much more grown-up conversation with them about the joint brokerage, the joint packages of care. I'm pointing at Katie because this sits in Katie's area. And I agree that the way that they behaved 18 months ago was completely inappropriate. And I think that it's been acknowledged as a system that we're in a different place now. What I was trying to explain was that the way the two frameworks work, it is perfectly possible to end up in social care holding the care baby, if you like, in the same way that the NHS hold babies around urgent care. So if I fall in the road, ambulance picks me up, takes me to A&E, I'm responsible for that. So with supporting people in the community, there's an adult social care responsibility. So I didn't mean to mislead by saying that, that I was kind of trying to describe the way that the two frameworks work together. And it's been a national policy in the NHS to be reviewing. So the NHS is under financial pressure in the same way we are, and they've had a national policy to review their community investment, and that's what they've been doing. And then I don't think I said I can't do anything about the black hole or that I'm not concerned about it. I think I was just describing that it is quite a small variation on what is a very large budget and what makes up a very large amount of the council's overall budget. And that we've faced really significant increases in the cost of care, which I don't think they're going to be existing a risk. We're not got any evidence that the cost of care is stabilising across the country. So it's going to be keeping up the mitigations. So the mitigations have delivered about 30 million of benefit. It's not been the whole of the risk that I was facing, which is why there's an overspend. But certainly not that there's nothing that I'm complacent about having an overspend. So apologies if I gave that impression.
I think it's worth becoming chairman. I think when I say about ground approach, Councillor, as we've already just shown, Minister Mel just said, we've managed to get to the point now where the behaviour has changed and we've been mitigating the risk as much as possible that this will never happen again. The whole point is, as I'll say, it's not entirely our gift to say that, it isn't their gift, and whatever yourself or Health Group you want to do in terms of speak to ICB is entirely, obviously, your choice. I think there are other councils out there who, like I say, have just gone down the legal route, etc., and they are still having those huge risks financially. The way we've gone around negotiation was because we need to know that certainty for the budget as much as possible, and not just the budget, obviously ultimately looking after our people where we were going to be. So, as I say, the risk could be a lot bigger if it wasn't down the fact to the team in terms of working with the NHS ICB. And I probably even around the budget there, when we say about the variation, as Mel said, although it is 3.8% in the whole wider budget, it obviously looks a small percentage. It is taxpayers' money. Can we agree with you? That's why we are working so hard to reduce the risk down as much as possible, as we've already outlined. If we just sat there and gone, the ICB did this to us, we're going to have this huge overspend. We could have, I think, just sat here and gone, we're 30 million overspend, it's all down to the ICB, etc. We've just said, no, it is taxpayers' money. Let's reduce the mitigation down as much as we can. So, of course, we'd like that down to be down to zero. Of course, we would, and we're going to keep working day in, day out to reduce the risk as much as possible in the overspend. It's just trying to be honest and realistic to the community in terms of why we're in the position we are and also the work we're doing. So brokerage has had a huge impact already, and we'll do it next year in terms of negotiating those care packages, because it's so important to actually have professionals there a finance who can do that and let our carers do what they want to do, which is care for people. And so that consistency can make a huge difference. The technology of care, we've just shown already the difference that's making in terms of the overspend. So I think there will be a lot of benefits next year in terms of transformation work. It's just can't take all credit for this year's budget because it's not an overnight process, but we're doing what we can to reduce that overspend as much as possible.
Thank you very much. Councillor Martin.
Yeah, I'm just concerned about going forward. What process have we got to change the situation, because it's just going to get worse in April, isn't it? You know, I mean, when all the extra national insurance kicks in and the living wage and all that, it's going to exacerbate a problem that is already on your side. You're saying it's a small part of your budget, but nonetheless, it's still a figure that we've got to deal with going forward, isn't it? So what are we going to do then? What process are we going to go through to try and get proper funding for it from the government?
Can I just do a supplementary there? Could you just enlarge on the issues, why they were withholding money? Because obviously they hadn't got a legal case, otherwise they wouldn't have paid it in the end. So I know you've done it through negotiation. You might just enlarge on that a little bit, please.
Yeah, but we're quite limited to what we can actually say, Chairman, because a lot of it's around legal issues in terms of.
I see.
But I think the point from Councillor Martin, you're quite right. You know, the report I'll be taking to Cabinet next month on the care fees will show the huge extra increase that we as a council are putting in to meet that duty, because we have that legal opportunity in care to give a fair price for care. So I can't just go we're giving all our care providers 1% increase, because one, they're probably saying no, thank you, we're not going to do the packages because we will lose money. But two, legally, we know it costs more than that 1% because of the impact of the budget that's taken place. So there is that huge additional pressure, which you will see going forward. I think it's what we keep doing, which is lobbying. So I don't know what to talk about this other said, but all that ADAS are doing in terms of trying to make that clear to government. And I think you're going to select committee, aren't you, later this week about it as well, if I remember correctly, in that role. As a council, you already see what we tried to do in terms of lobby the government for extra funding. That's worked to some extent. We've had some bit of extra money than we expected, which is not all we need. Obviously, there's still a huge pressure, but it's obviously welcome to get any additional funding, because that helps reduce our budget down. But I think it's just keep outlining to government publicly that we do need that extra funding, whatever colour of government it is, to give that. Because, as I said at the start, social care reform is a big one for me, because it all keeps pushing on the road. The issue is not going away around social care, is going to get more. So we need to address that head on, and to keep doing reviews and more commissions. It just keeps pushing it down the road, in my view. And so we need to get there. And I think the extra increase is what we just need to know. So there's more transparency up front. So if we know when setting a budget where we're going to be, but I just say when you do get announcements ad hoc or that they don't match up the budget cycle, these are extra costs, as we always have that national living wage. Completely welcome our staff are getting extra wage there, but if we know that what that increase would be for that government, and we know for next year and the year going forwards, then we can budget for it appropriately, properly, and can look at that. But when it's an extra cost on top, that just puts extra pressure on us to find that extra money somewhere else to meet the overall budget. So it's just about keep communicating, keep highlighting the issues so that everyone can play that part. And I do appreciate everyone that can across the table, and to work with our MPs. And I know a lot of them do understand that in terms of taking that forward and to make the case for us to government. Yeah, that's what I know. Okay.
Thank you very much. So all the questions, nobody else wants to make any questions. The recommendations have been moved and seconded, and we're on page 74. So all those in favour, please. Thank you very much. That's unanimous. We move on to item 8. Public health performance, risks and financial position, quarter 3, 2024, 2025. I ask Councillor Scott Carlton, Cabinet Member for Communities and Public Health, to introduce this report.
Thank you, Chairman, and good afternoon, colleagues. The report summarises the performance, risk and financial position for public health. In quarter 3, performance of public health services continues to be strong, with a delivery of majority of key performance indicators. Although for the eagle eyes, you will notice some seasonal variation is also witnessed. There were improvements in a number of performance areas and services. For example, from the 8,110 eligible patients invited to a health check, and 5,301 patients completed one. The amount of completed checks since the onset of the COVID-19 pandemic. This is significantly more than the last quarter and the same quarter last year. whilst the procurement of a new service, progresses well, the current Healthy Families programme continues to deliver for Nottinghamshire families, with all 4 local service indicators stable or better than last quarter. One of the many stories of difference the report illustrates the positive impacts this service has on school-aged children, as well as those receiving support in the first 1,001 days. The report contains a deep dive on our new Nottingham and Nottinghamshire Sexual Health Service, which has been operating since the 1st of October last year as a single service across the city and county footprints. As it's indicated, that the service is jointly commissioned with Nottingham City Council and provides all levels of sexual health care, from health promotion, education around sexual health and well-being, to testing and treatment of STIs, and offering a comprehensive contraception to prepare to all those that seek it. Performance against the annual delivery plan is either complete or on track for priorities by the division. Briefly into sort of the money aspect of things, that the period 9 budget monitoring for the current financial year indicates that the public health ring-fence budget is currently underspent in year by £440,000, which is 0.9% of the overall annual budget. I won't regurgitate my words at full council, but just to confirm that the public health grant for 25-26 is just over £48.5 million. And as in my budget speech, I did mention the ongoing pressures and the greater understanding of the impact of national insurance changes. In the terms of workforce position for our team, not including commissioned services, continues to be strong, with turnover and sickness absence rates low. They have got reduced since the last quarter. There have been no significant changes to the risk register, with no risks in the public health division currently rated as high. I will now pause and briefly hand over to both the Director of Public Health and Communities.
Councillor Coulter. So you will see there were some slides in your agenda pack, and I'm just going to cover some of the key messages on that, so that will be within the pack. So as Councillor Coulter has mentioned, in really nice ways of really identifying, I know some of the previous conversations we've had around really getting that assurance around the Healthy Family Programme, but also filling that broader age group that we also finish that emotional boundary and well-being. In terms of our sexual health service, I'll leave Alex to comment on that shortly. What's really important is seeing that continual improvement around our health checks and performance, and actually seeing some of the greatest amounts of health checks being taken up in this Q3 than we've seen before COVID levels. There's some really positive improvements there. In terms of our Healthy Families Programme, so on page 100 within your pack, you'll see that we're still sustaining that high performance for our mandated contacts, and that we're seeing either similar or increased performance on all of those mandated. That's really good as we're moving through that procurement. In terms of the actual procurement itself, so there's a 2-stage procurement process that we're just working through. We're just in the final stages of that procurement process, but we're still on track to hopefully identify our preferred bidder by April. We've got an additional slide this time around the childhood measurement programme, and this is a programme which is part of the service that basically weighs and does height measurements of children to understand where they are in terms of being a healthy weight in reception in year 6. So we only report this in Q3 because obviously the programme is doing it over the year. But that's when we know when we're getting that overall approach. And what's been really positive here is we've had a really high participation rate. So we've actually weighed over 92% of those young people, which gives us a really good quality data in terms of understanding where we are in terms of our obesity levels. What I have highlighted here is where we are in terms of the actual outcomes of that programme. So in terms of the delivery of the service, we've been seeing nationally, that's been nationally recognised in terms of our good practice. But what I wanted to highlight here is that actually in terms of the overall outcomes we're trying to understand here is we still have significant levels of children are overweight and obese in reception, at about just over a fifth of reception children. And when that moves to year 6, just over a third of our young children are either obese or overweight. And now, in comparison to the national average, we're similar to that, so we're different to that, but that's still a significant proportion of our young people that are within that category. And you know that being overweight and obese has significant impacts on the low overall well-being, particularly in those areas around early death in terms of cardiovascular disease. So it's still some work that we want to do. And we do know that this is an area that we continue to see health inequalities around. So we know that we have higher rates of being overweight and obese in our actual menstrual capacity. So I just wanted to highlight some of that. In terms of next slide, in terms of our integrated wellbeing service, we're again seeing some of the highest performance that we've seen in this contract. So continuing to deliver high performance against on 4-week critters, so our smoking indicators, but also our weight management indicators. In terms of homelessness, we've got a slide on 103 in the pack. This is an area that we are still finding challenging in terms of our performance, and this identifies some of those complex system challenges where we're struggling to get through the throughput in terms of making sure we start longer term accommodation for people that are struggling with homelessness. So we have seen a drop in central people from moving on accommodation in a planned way. And we are still on target in terms of where we'd like to be in terms of people exiting from hospital accommodation. And that really does link into what is the follow-on in terms of the system that we can support those individuals. But some really positive work is being done to understand those that are exiting in a planned way and what positive outcomes they're having in and then in terms of some wider updates on substance use and domestic abuse and some really good service development areas in those. Councillor Carlton has already mentioned some of our progress on our delivery plan, so more than happy to take some questions on those. And then what I was going to do is just go over to Ellie Finance, just to give us a little bit more detail around that new mobilising.
So Councillor Carlton already went through the update around the new service launching in October. So this data refers to the first quarter or the first 12 weeks of this service. We've been really pleased with the successes of the service in terms of mobilisation. So a fairly short mobilisation period, about 6 months, and then they've been up and running since October. We've seen this as the bringing together of lots of services and a new single point of access for sexual health across the system. And we've been really pleased and really assured that our residents have continued throughout this period of change to receive good quality, high quality clinical care for their sexual health and reproductive health needs. We've also, through that time, maintained really high rates of access, so our appointment rates have dropped. We've also maintained really high rates of access to long-acting reversible contraception, which shows that we've got really good contraceptive counselling for our young women, or for all of our women of reproductive age across the county. We've had some variation, which is to be expected when we're mobilising a service at this scale. But what we've wanted to do is we've examined this with our providers. We've had some variation around chlamydia testing and HIV testing in service. One of the things around these indicators is that they exclusively look at the testing within the terrestrial services, so within one of our 20 clinics that happen in the county, and they don't account for some of our online activities. But now that we have a single online and terrestrial service in one contract, we might want to continue to think about how we want to report that moving forward to reflect the full spectrum of the activity that's taking place in this space. Because, for example, if a young person does a test online 3 weeks before they then go into clinic for, say, their contraception needs, their advice wouldn't be to retest within that time frame. So we're potentially missing some of that activity. So we'll continue to look at that, continuing to try and destigmatise and promote testing, increasing our testing rate more broadly, and wanting to increase access to testing for those groups that are potentially at high risk, who are less likely to come into our services through our health promotion and outreach team, who are going out to schools, sexual premises venues, community venues, etc. etc., to engage with local people and support them to improve their sexual and reproductive health.
Thank you. So that's the report. And with the recommendations as detailed in the report, I have a seconder. And I ask Councillor Dare to ask the first question.
I'm just looking through all the stats and full of stats. There's one thing on public health that really gets me going, and has done for some time. I say it's not even, I can't even find it mentioned in these stats. Tobacco is mentioned, but vapes are not mentioned. Vapes are one of the major problems that you see now, causing problems all around our young people, their public health. In 5 to 10 years' time, we didn't understand cigarette smoking, and now we don't understand vaping. We need to get a grip at that somehow. And I know it's a subject we've talked about before, about public health, and I said, it's been lost somewhere, I'm not sure, but I would suggest that we've got tobacco on there, we've got vaping on there as well, and we get some focus on it. I know the NHS says, oh, packing smoking by vaping, but that ain't working. When you talk to people, vape now, they've gone off the list, now they're vaping more than them. And the other thing about vaping is, you can't smoke in a public place, you can vape in a public place, you have to sit there with all the vapes going around you, and I think we need to get a focus on this somehow going forward. It may not be a big issue today, but in 5 to 10 years' time, I will think. So, on that side of it. And also, you save some money in your budget. Could you have spent it on doing something on that front? Oh, thank you.
Thank you. Go ahead.
No, thank you for your question, Councillor Dare. Also, there is a lot of national attention in this at the moment, not just on tobacco, but also on vapes and from experience in this subject. But also the debate, if I was being perfectly honest, has also become a little bit skewed in that vapes were at one point seen as the quit aid. Obviously, we've seen an explosion down at the other end of the age range, and across for those that have never smoked tobacco in the first place, but then have taken up vaping to start with. Certainly from a public health point of view, a few weeks ago, that's where the trading standards team that have been out on a raid to a shop in the north of the county and seized thousands of pounds worth of illegal vapes that, to the point that until they're tested, we do not know what's in them. So there's a significant health risk there. We wanted to expand further.
I can do. Thank you, Councillor, and thank you for your question. So in terms of where we are from an evidence-based point of view, in terms of vapes, there's still really strong evidence that vapes are a really effective quit aid for those people that are smoking tobacco products. And I think that's something that we would want to continue that, because we know that we're seeing some really positive results in terms of our smoking prevalence in the community, which has reduced in the last second that we've seen. Because of some of those additional quit aids. So there's something for me around absolutely acknowledging that these are really effective quit aid, but also acknowledging the really valuable points that you make there in terms of the fact that we don't want to be encouraging our young people to maybe take up vapes when they wouldn't have necessarily done that before. And what I'd like to do, if I may, is provide some reassurance around the fact that there's still a lot of work going on in the background around making sure we're really clear on our strategy around vape quit aid, but we don't want particularly our young people to start setting up and starting to know habits around vapes when they wouldn't have done before. And a lot of work is going on with our Happy Families programme, with the Intent programme, which is specific programmes in schools around smoking, but also some of the broader workforce and partnership work around that. And if it's helpful, we're more than happy to provide a bit more deep dive on that in the next report, if that would be helpful for you.
For me, I think it's so important. When I see young people coming out of school, and the first thing they do is get a vape out. That is not a quitter. That's a starter. And somehow the focus is on the quitter and not on the starter. And you need to get a balance between both. I mean, unless we lead from the front on it, Nothing's going to happen.
Absolutely, and I think certainly we're really keen to make sure that we are supporting that, because we know that there is evidence if you start taking up vaping, then there is a risk that might lead to other addictions, whether it's tobacco or whether it's any other addictions. So we're really keen to work on that, and we can certainly make sure that we provide some more specifics around exactly what we've been doing more recently around that, if that's helpful. And the other thing just to highlight as well is that we now have a specific grant around having a generation of non-stop smoking, and we have invested an additional just about £1 million, I think, over the past 12 months our tobacco control approach, and that broader approach which will include vaping as well. So again, if that's helpful, more than happy to provide you with a little bit more detail either offline or in the next.
See, I mean, the big problem we've got all the tobacco shops have disappeared at the high street. They've all been replaced with vapes and fancy vapes and this colour vape and that colour vape. Who's buying it? The young people. You can see them. I mean, I see them in my own villages. There they are, hanging around the vape shops and all the rest of it. So for me, I know I'm getting into the older stage, but I know what happened in my young years. You know, smoking, no, that's all right, I don't like. But it wasn't all right. And having a vape, that's not all right either.
And if I may just come on to that, there's a lot of discussion nationally as well around the latest tobacco duty legislation, around what will or won't be in that, which will also combat some of those things. So we know that there's particular, like you say, branding or flavours and those sort of things around vape, which are attracting more of a younger audience. And some of that work nationally will also support that, but it also leads into the point that Councillor Carlson made around working with our training standards and services to make sure that the vapes are available, are the ones that are supporting people who are quitting smoking, but also that we're working really positively around making sure that the advertising and the type are as safe, like you say, not encouraging our young cohort population.
One last thing, is there anything going forward in legislation to say that vaping and smoking should be banned in public places? I know smoking's banned, but vaping should be banned as well. So why should I sit next to somebody who stopped smoking and that made it a pleasure for me, then have to sit next to somebody who's vaping? That makes it discomfort for me. I'm not the only one to say it. I'm speaking on behalf of a lot of people that I talk to.
And if I may,
yes, by all means, go ahead.
There's a lot of debate about what's going into the latest tobacco legislation, because there's a lot of discussion around the impact of second-hand smoke, and exactly the point that you've just mentioned there, that actually there is quite a lot of evidence around if you are next to people that you don't know whether that person is either a young person or has chronic conditions, that condition might be exacerbated by smoking. So there's a lot of debate in that space at the moment. And I think we need to see what comes out nationally in terms of that. But I think that it's certainly an area that we are very aware of, and that there's a lot of work going on locally and nationally to understand.
But are we inputting to that work?
And we are inputting, yeah. So there's been a number of surveys that myself and the team have been inputting into, certainly a lot around the latest tobacco bill, and in terms of what we might want to shape that in terms of. Obviously, we need to see what gets agreed nationally, but certainly there's some really positive sounds that are coming out of the movement in terms of that bill, which I think will help us in terms of that overall message around how we're supporting our population to be smoke-free, which is something we're really keen to progress on.
Don't lose the focus on it. I won't be here when it's a problem, but somebody will.
Thank you. I have no further councillors wishing to speak. The recommendations moved and seconded. All those in favour? That's unanimous. Thank you very much. So we'll move on to item 9, and that is the work programme. Martin.
Yeah, just to kind of like link into what was just said, we have got down on the work programme as an area of review, and it's just pending like the new legislation to look at the impacts and effectiveness of the preventative work that takes around the schools around smoking and vaping. And just on the last item, I'm sure if members, because we had quite a conversation there about the work, and I know they've said more information was available, so perhaps if more information could be circulated about the work that's going around tobacco, that would be really useful for committee members. So the work programme on there, it's not the last meeting on the work programme, but it is the last meeting for the election. So it's just to note that we will be redeveloping the work programme in June and July. Obviously, we'll use this as a basis, and obviously the membership of the committee at that time will have an opportunity to input into that, along with officers who can make suggestions. In the meantime, if you haven't got anything else that you would like putting on there as a pending item, so we can take that forward, just let us know.
So no comments on that. In that case, I close the meeting. Thank you all. Oh, Councillor Kerry.
We're going to vote on it.
Oh, right. Yeah, we'll all agree to close the meeting. Yeah, good. Yeah, work programme, exactly. Yeah. Well done.